All right, everybody. Why don't we go ahead and get started? Good morning again. This is Mike Bell. I'm here with colleagues at CDC. Today we're going to be reviewing some of the issues related to personal protective equipment. But before we start, I'm going to pass it to Dr. Anita Patel, who will give us a quick overview of the current outbreak.
Great. Thank you. Thank you, Mike. So as you all are aware, we have been monitoring this expanding outbreak of respiratory illness that's been centered in China. This is a novel coronavirus, and we've been calling this the 2019 novel coronavirus. Right now, we've seen virus outbreak in 27 locations across the world. It's impacted over 40,000 individuals, and in the U.S. right now, we have 13 cases across 6 states. The potential global public health threat posed by this virus is high, but right now, the immediate risk to most Americans is low, as most cases still are limited to mainland China. Right now, the virus is not spreading in communities across the United States, and the vast majority of Americans have a low risk of exposure. The greater risk is for people who have recently traveled to China or their close contacts. This is a rapidly evolving situation, and the risk of assessment for Americans will likely change. The federal government is working closely with our state, local, and tribal and territorial partners, as well as public health partners and the healthcare sector, to respond to this public health threat. The public health response is a multi-layered response with the goal of detecting and minimizing introductions of the virus in the United States to reduce the spread and the impact of the virus. Strategies are in place to reduce the number of travelers from China in screening, and you may have heard about some of that in the media. The U.S. public health system also is on high alert to detect cases of 2019 novel coronavirus infection and prevent further spread within communities. The success of this response efforts will determine what happens in the coming weeks and months and what will happen here in the United States. While leaning forward aggressively with the hope that we will be able to prevent community spread, we're also preparing for the worst. The current outbreak meets 2 criteria for a pandemic. It is a new virus, and it's capable of spreading person to person. Extensive work has been done over the last 15 years to prepare for an influenza pandemic. Influenza pandemic preparedness platforms and plans will be appropriate in the event that the current 2019 novel coronavirus outbreak triggers a pandemic. Here at CDC, we have implemented an incident management system. This system is coordinating all of our activities, both domestically and internationally. We have deployed teams to the areas of the country where we have these 13 cases to learn as much as we can about this virus and its transmission. We also have moved some of the lab testing capabilities down to the state and local level to do more efficient testing and, again, learn more about this virus. We will continue to provide guidance to healthcare system and to clinicians on what to do next, and today's webinar will provide additional details on what we're doing in terms of supply chain for personal protective equipment and the overall approach we're taking to infection control. And with that, Mike, I'd like to turn it over back to you.
Great. Thank you, Dr. Patel. So let me spend just a couple of minutes describing infection prevention and control approaches that are currently being implemented and recommended, and some of the implications related to that. This virus is a respiratory virus related to the viruses that cause many ordinary colds. It is not something new in terms of type of pathogen, and we have a lot of information about what needs to be done to prevent spread. Thing number 1 is source control. Preventing someone from coughing openly or sneezing openly is an incredibly effective thing to do, and you'll see that in all of our guidance, the first thing that we promote is getting a simple mask on the person who's ill. This can have, from a physics perspective, a much bigger impact than trying to put protective equipment on people around them. So source control is thing number 1, and that just requires a simple surgical mask. And if this changes, and in the future we need to deal with community transmission, the source control there can be done with handkerchiefs and similar objects. The good news is we currently don't have active community transmission in the United States. All of the efforts, and they are significant, that the nation has put into place to prevent importation unknowingly are all geared towards stopping the or at least slowing the arrival of community transmission, which, as you can imagine, creates a much bigger challenge for health systems and communities across the country. One thing that we do know from MERS and SARS is the ability of healthcare delivery to amplify transmission if we're not careful. We've seen in both of those instances that if there's a lot of interaction between patients, visitors, family members, and if healthcare delivery isn't done in accordance with appropriate hygiene practices, that hospitals can become locations of tremendous fast amplification, and that's something we certainly don't want to see in this country. Because of where we are, as you heard, 13 cases recognized in the country so far, despite a lot of active testing, we are able to be very, very careful in our approach. So right now we're saying that in addition to routine standard precautions, we recommend that these patients be cared for using contact precautions and airborne isolation using a negative pressure room. This is in addition to using a negative pressure room for aerosol generating procedures, and that people wear respiratory protection and eye protection on top of it all. Now, the eye protection is easy to forget about, but as you know, people can cough, and if they cough into your unprotected eyes, you do have tear ducts that lead to the back of your throat. And so we don't want that to happen. That is something that is easily forgotten, and we keep reminding people because it's certainly a vulnerability. Do we really think that airborne transmission of this virus is happening often? We don't have any evidence to suggest that it is. This is not behaving like measles that would completely infect a massive shopping center all in one day, right? We're not seeing that pattern. And so we feel like we're being more conservative than is absolutely required. And that gives us the ability, with ongoing assessment and new information, to start planning ahead for how we might change our approach. We don't expect to use airborne isolation and respiratory protection forever and ever for viruses of this sort, but we do want to make sure that if we loosen our requirements a little bit, it's after we know just how bad this can be, which populations are most likely to be harmed, and whether there are specific parts of the healthcare system that might be more vulnerable. What I can tell you is that from what we know from previous coronaviruses and respiratory infections in general, ambulatory care settings, acute care, emergency departments, places where people with symptoms walk in are certainly high on the list of concern. We're messaging very strongly that patients seeking care who have had travel exposures call ahead. And if you receive such a call, we're messaging to healthcare systems that those individuals should be asked to put a mask on before they arrive. Any assessment should be done in a place where they're not exposing other healthcare staff or other patients. So a separate exam room. If you have a negative pressure one, go ahead and use it. In this country, we have a lot of resources, and we're okay with saying go ahead and use them if you have them. You'll see that in many other countries around the world, the recommendations are different, mostly because they don't have the resources and bandwidth that we have. I have a hunch if they did, they would be doing something similar. As I said, this is an ongoing process. We're learning more every day. I would please ask that you frequently check cdc.gov/coronavirus. That's where all of our updated guidance is going up. We're updating things on a daily basis. We got helpful feedback. It was pretty obvious now that I think about it, to remember to put updated dates and what's new type boxes on our documents. So we're attempting to backtrack and put those in to make it easier for you to understand what's changed. One thing to point out is that we've heard clearly from you and others that supply concerns are starting to rise. Some of this is related to the fact that a great number of devices and types of equipment do come, in fact, from Chinese manufacturers. As their ability to produce is hampered by the outbreak, we are concerned that our supply chain can be impacted. We know that many purchasing organizations and distributors are now using a systematic approach to distributing available supplies, and that's a good thing. I will, before I hand it over to Dr. Marie DePerio to talk about our latest guidance on how to optimize supplies of protective equipment, I will remind us all that protective equipment is only one factor in safe and appropriate care. There are many, many other things that actually supersede protective equipment. Things like making sure that if an infectious individual doesn't have to be in your facility, that they are directed elsewhere. Using nurse triage lines, call lines, advice lines for people who don't require hospital care is an incredibly important thing. Including the option of waiting in one's private vehicle while waiting to be assessed if somebody is symptomatic is a great thing. I mean, we do it when you're waiting for a table at the Cheesecake Factory, so we should be able to do it in an emergency department and simply use their cell phone to bring them in when it's time. Those types of strategies to keep infectious individuals out of the healthcare system in the first place are incredibly valuable. Encouraging people to very quickly wear a mask if they're symptomatic so that if they're in the facility, they're not actively spreading infection to others is the second thing, and that gets back to the primary directive of source control. I'm going to stop now in the interest of time and make sure that Dr. DePerio has ample time to talk about the latest guidance. Dr. DePerio?
Thanks, Dr. Bell. So I'm a medical officer and a physician board certified in internal medicine and infectious diseases. I'm assigned to CDC's National Institute for Occupational Safety and Health, or NIOSH, and I've been heavily involved in the intersection of infection prevention and occupational health and safety. Next slide. So as Dr. Bell mentioned, CDC's goal is to provide sound infection prevention recommendations that protect healthcare workers and that are feasible and acceptable to implement. So as you already are probably all familiar, CDC has put out existing interim infection prevention and control recommendations for this virus in healthcare settings. So CDC also has additional new information on the healthcare supply of personal protective equipment, or PPE, and a screenshot of that is on this slide. Next slide. CDC also has guidance that recommends practices for extending the supply of N95 respirators in healthcare settings in the face of potential ongoing nCoV transmission in this country. So our guidance is written for professionals who manage respiratory protection programs, occupational health services, and infection prevention programs in healthcare settings. So as Dr. Bell mentioned, it's important to remember that the U.S. healthcare system responds to infectious disease threats every day. So the actions and strategies that CDC is currently recommending to stop the spread of nCoV are really not new. We've used many of these strategies before for threats like influenza, tuberculosis, and measles. So in occupational safety and health, we use the hierarchy of controls approach. So the hierarchy is framed as an upside-down pyramid, as shown in this diagram, where elimination and substitution are the most effective solutions. But we know that these are not typically options in the healthcare settings. So the next categories are engineering controls, which isolate people from the hazard, and administrative controls, which are practices that change the way people work. So finally, PPE is really the lowest on the hierarchy because its effectiveness involves a high level of worker involvement and commitment, and is really highly dependent on proper use and fit. So the optimal way to prevent airborne transmission is to use a combination of interventions, not just PPE alone. So these strategies can be implemented both concurrently or sequentially. So the strategies we introduce on this webpage shown here can be categorized as conventional capacity using language we've borrowed from the disaster world. And these consist of providing patient care without really any change in daily practices. So these strategies that I'm going to talk about should already be incorporated into existing infection prevention and control strategies, and many of them also appear in pandemic plans. Next slide. So engineering controls are controls that reduce exposures for healthcare personnel by placing a barrier between the hazard and the provider. So examples can include, using barriers such as glass or plastic windows in reception areas. Like good places for these are intake desks at emergency departments or information booths in emergency departments. Another example is use of airborne infection isolation rooms, which is in our current infection prevention and control guidance for nCoV. A cornerstone of engineering controls in healthcare settings is ventilation systems that provide air movement in a clean to contamination airflow direction, and it's important that they're properly maintained. Next slide. So administrative controls are employer-dictated work practices and policies that reduce or prevent exposures. Many of these examples are already in existing infection prevention and control guidance and can help optimize the supply of N95s within a healthcare system. So I wanted to highlight just a few examples and expand on them below. So an important strategy to conserve N95s is to exclude healthcare personnel who are not directly involved in patient care from the patient room. So in order to minimize the number of healthcare personnel who enter the room and then thereby minimize the number of N95s being used, staffing policies can consider excluding staff such as dietary and housekeeping employees. Another potential strategy is to limit face-to-face healthcare personnel encounters with a patient. So as an example, healthcare personnel may consider bundling care activities to minimize room entries. Excuse me. Another strategy that is already included in many general infection prevention and control plans is restricting visitors from entering the rooms of patients with known infections. So alternative mechanisms for interactions might include video monitoring or video call applications on tablets. Also, as Dr. Bell mentioned, one cornerstone of infection prevention in healthcare settings is this idea of source control. So just to reemphasize, it's important to identify and assess patients with symptoms of suspected nCoV or other respiratory infections. So when these patients present to care, they should put on face masks for source control until they can be placed in an airborne infection isolation room or at least a private room. So patients with these symptoms should not need to use an N95 respirator. In addition, cohorting patients is the practice of grouping patients together who are infected with the same organism to confine their care to one area. We've used cohorting extensively for managing outbreaks of multi-drug resistant organisms, and cohorting was also used in the SARS experience. Cohorting healthcare personnel means assigning designated teams of healthcare personnel to provide care for all patients with confirmed or suspected nCoV. This can be another strategy that may limit the number of healthcare personnel exposed and who need to use N95s, and then also limit the number of healthcare personnel who need to be fit tested. Finally, some facilities may adopt a plan to use the just-in-time method for fit testing, which has been incorporated into many pandemic plans and facilities. So for large facilities, it may not be feasible to fit test all employees, especially if their job does not typically place them at risk for exposure to airborne infectious diseases like tuberculosis. So these hospitals have the capacity to do larger scale training and fit testing when necessary during a pandemic. Next slide, please. So while engineering and administrative controls should be considered first when selecting measures, the use of PPE can also be used to protect healthcare personnel. So our guidance in our webpage outlines additional conventional capacity strategies, such as defining when to use surgical N95 respirators. So our worker safety and health team has fielded multiple inquiries about the indications for use of surgical N95s. So surgical N95 respirators should not need to be used outside of healthcare settings. In general, healthcare personnel providing general care to nCoV patients should not need surgical N95s. Surgical N95s should be used by healthcare personnel who are working in a sterile field or those who may be exposed to high velocity splashes of blood or other body fluids. Another potential strategy for optimizing the supply of N95 respirators is the use of alternatives that provide equivalent or higher protection. So these include other disposable filtering facepiece respirators, such as N, P, and R, N95s, 99s, and 100s. In addition, powered air purifying respirators or PAPRs can be used. So these are reusable respirators that are typically loose-fitting hoods or helmets with a HEPA filter. And finally, elastomeric respirators could also be used. It's important to note, though, that PAPRs and elastomeric respirators are reusable, so they should have up-to-date cleaning and disinfection procedures. So in closing, I wanted to emphasize again that the strategies I've outlined here and that are in our guidance really are strategies that healthcare facilities should already be incorporating into their existing infection and prevention programs. All of these strategies may optimize and thereby conserve the supply of N95 respirators. And now I believe we're going to hear from a couple healthcare systems about their real-world experiences.
Great. Marie, thank you very much for that. I think the next speaker is going to be Skip Skivington, if I'm not mistaken.
Yes, hi, it's Skip Skivington, and I believe my partner in crime, Dave Witt, is on as well, so we'll kind of do a tag team and share our experience at Kaiser Permanente. For us, it feels like deja vu all over again when we look at the long arc of these kinds of situations that we responded to as an organization. And for Dave and I, it goes all the way back into the 90s as we were preparing for the Y2K millennial celebrations and the threat of bioterrorism. And then it hit us personally in 2001 with anthrax, and then SARS, H1N1, and Ebola. So some of the characteristics of that impact to the organization are very, very consistent, and it's just heartwarming to know that there's so many people out there that are interested in this, and you and I walk in pretty much the same shoes in our facilities, because as soon as we heard that there was an issue circulating in mainland China, we could, feel the heart start racing a little bit more than normal, because we knew what to expect, and sure enough, it's playing out that way. So not that we think that we have the answers, because we don't, but we do have a great partnership with all of our health partners from the federal, state, and local level, and it's through this cooperative practice that we think that we're as prepared as we're going to be. And then we also, I just saw something come across that we named this, so I guess the WHO is calling it COVID-19. So we have a formal name for our friend and foe here. So if we can, Dave and I just had time, because we've been, like you, working around the clock to get ready. So we just kind of listed out on a slide, not too sexy with any pictures or anything, that lists out what we've been doing. One of the things that, I don't know if it was serendipity or if it was master planned by the CDC, but we've been talking with Anita and her team for a number of months about their Health Pulse program, and so we've been participating with them. And that, if you're not aware of it, is one where they want to dip down into systems like ours to see what impacts that are occurring at the ED. So we're basically using the NEDOX scoring, and we use that really quite successfully during seasonal flu, because it's a early indicator if our ERs are being impacted. And if they are, then we move our incident management system into high gear, get all the nursing directors and leadership at our facilities online, so that we can see where we're having the hot spots, where we can decompress if possible, shift patients, shift staff to cover and stay on top of the situation before it turns into a more troublesome pattern. So you can see the usual things that you would think. Dave and I have had the privilege for the last 20-some years to co-chair our national clinical work group. So we bring together in sort of a wiki experience to kind of get the latest situational awareness throughout the country, get alignment on some of our tools and products that we share within the organization, with the attempt to get the best information, the best science, the best possible products, and we share extensively, and we encourage people to plagiarize shamelessly, so that local folks aren't having to reinvent the wheel for certain that they're needing in their facilities, like signs, like workflows. If you'll see in the middle of the page, we are an Epic house, and so Health Connect is our internal term for our EMR. And so we coalesced around a set of patient screening questions, and as Dave can attest to, lots of sharp elbows and bruises that went into that effort, because, if you ask one clinician what they'd like to see for on a screening questionnaire, that's then you heard one voice. So there's many, and sometimes it's a really a long struggle to land on a common space. But when we do, we find that that's usually works pretty well because of the rigor and the passion that goes into coming up with with the right workflow or questions. The other thing that we've done that's similar to with the PPE conservation is for our medical office buildings. When the virus first surfaced, everybody wanted N95s, and as you and I know, you probably saw boxes or cases or pallets of N95s potentially going out the back door. We've heard credible stories of people willing to pay $100 of their own money for a box of not even N95s, surgical masks, because quite frankly, we're seeing the burn rate on our surgical masks going up much higher, surprisingly, than N95s. So we put in pretty aggressive techniques to kind of control the flow. And even though you and I and our facilities are under allocation from our suppliers, if you can get them, because some of them I understand are on back order, but we're certainly on allocation from our main suppliers. And we're doing the same internally. So we set some measures. We can look at what's normal run rates, and then we kind of keep our eye on that, and we let this facility know that we'll allow for some additional usage beyond the run rate, their normal run rate, but we'll cap it there, and they have to put in a special justification. So we were already in a high alert mode within our supply chain, because that team and our whole organization had been affected pretty deeply with the Cardinal recall. So with the surgical gowns, and then for us, more impactfully, we had quite a few custom procedure packs that were also impacted. So we were basically scrambling day to day, and they did a Herculean effort to keep ahead of that disaster in its own right, to prevent any surgeries from being deferred or canceled. So since they were already in that high alert mode, this was just a natural thing for them to stay engaged and keep their command center operational, and to give us updates on our aggregate supply chain situation, and then what the local facilities look like. So they've been really our personal heroes so far through this crisis for us. So I'll take a pause, and Dave, and see if you wanted to add anything to anything that we just talked about.
Yeah, I think...
Just real quick, sorry, knowing we're close on time, and Dave, want to give you just a minute so that we can move on. I want to make sure there's plenty of time for questions and answers. I do want to highlight a couple of things that were on the slides that I think was so good that you were pointed out. One are steps that we could take, that they're taking now, like prioritizing early fit testing, partnering with waste management to work through any clarifications that need to be made about waste, and even coming up with a protocol to send to your nurse line and advice line so that they feel ready to answer questions from patients that might come in. Those are easy, practical steps that it sounds like is really helping you guys be well positioned to make best use of the supplies that you have, and to ensure that people who don't need to come in for healthcare don't come in and potentially expose others or get sick themselves. Dave, I want to give you 1 minute because I know your insight is important as well. Is there anything to add to that?
Yeah, no, I think looking at all portals of entry was critical. You know, we have online appointments, online advice, the advice centers, and all of those fairly immediately had the screening questions for symptoms and travel to China. We developed, the workflows became critical. We have multiple communications channels because no one communication channel is really effective, and we know it. So it's gone out repeatedly to make sure to try and get it to frontline staff, and certainly to all administrators and to all departments that are high risk of this being a contact, primary care, emergency department, urgent care in particular. And I think that's actually penetrated pretty well and kept it fairly rational. We are also looking at the concerns we're getting from staff and trying to be ahead of that. When we have a question, we're trying to address specifically that information. And so far, it's actually been a pretty reasonable response by staff. We aren't seeing, generally not seeing people using extraordinary protection when isn't needed. And we haven't seen really discrimination against folks that we would be concerned about, against people of Asian ethnicity and that sort of thing that can come out very quickly in this kind of setting. I think that's pretty much.
Dave, and I think it's so important that you point out that the more that you're communicating with their employees, the more that they feel like they're in the know and they're looped in and that their management feels prepared, the less likely they are to panic and maybe use supplies that they don't need, and also, and really importantly, that they don't feel like they're discriminating against others simply because they're afraid. So it sounds like you're not just preparing them from a planning perspective, but a communications perspective as well, which is amazing. I do want to pivot us, just in the interest of time, to Dr. Rebecca Bartles. She has great insight because she's actually, her facility cared for one of the few patients we have right now in the United States with novel coronavirus. So she can speak to the on-the-boots experience and the practical ways that her facility's been able to address the first case, and then the ways that they're going to plan to addressing these needs moving forward. Dr. Bartles?
Excellent. Thank you so much. If we can move into the next slide, just a bit of background. I think all folks are aware of the initial case in Everett, Washington, that came to us on the 20th of January. And in response to that case, our BEST team, which is Biocontainment Evaluation and Specialty Treatment Team, was initiated. And we initially responded to this patient in the same way that we would, a dry Ebola patient, because our team had been drilling, they were geared up and ready to go. And with this being the first case in the U.S., we were operating with an abundance of caution at the direction of our local Department of Health and CDC colleagues. Next slide. So our first set of PPE looks like what you see on the screen here. We use cappers or pappers, the AAMI level 4 gowns, impervious boot covers, double gloves with the extended cuffs, and then we provided scrubs and shoes to our caregivers. We used our biocontainment unit. Patient was transferred in a biocontainment pod, and we definitely, at the time, it was the right thing to do, but, certainly a bit of an overdue for the pathogen that we're looking at. Next slide. So very early on in the process, we right-sized the response, again, at the guidance of CDC and our local health department, to be more in alignment with the CDC recommendations at the time of contact and airborne with eye protection. So we moved down into the AAMI level 2 gowns, still using double gloves, or we still use double gloves just because of the logistics of removing pappers and N95. The double gloves helped in that doffing process, and then obviously the respirator. We were able to estimate for our one patient the amount of usage, and I felt like this material was important to share for those of you that are doing surge planning. when the patient was relatively stable and feeling well, we used about 6 sets of the PPE that you see there per shift. We had 2 designated nurses on the unit. When the patient was feeling sicker and was running fevers, we used about 20 sets per shift. So in our surge planning, we're doing kind of an 80-20 split of those numbers, just based on what we've heard about the percentage of patients that have more severe disease. Next slide. So that's background about what we did initially for our patients, but that's one of 51 hospitals and closer to about 1,000 clinics at this point. We've got a lot of variation in what care settings look like in our organization, and we want to make sure that we're responding appropriately across all of them and keeping our caregivers safe. Next slide. So I'm not going to talk about the other parts of readiness. The things that our colleagues from Kaiser shared are, we've got parallel processes in place, really that reflect most of those. I'm going to speak specifically about the processes that surround our PPE. So a few assumptions before I share our workflow. We conducted a risk assessment. We've continued to risk assess with every decision that's being made, particularly in light of shortages. We do know, as the first speaker shared, coronavirus is primarily spread via droplet and contact routes. And then within our organization, we have a travel screen in place, and this travel screen has fired around 700,000 times since the 21st when we turned it on. But it hits everybody at every point of entry, and anyone that calls to schedule an appointment is asked travel screening questions. And so we've got a pretty solid wall around those places where patients are presenting to be able to quickly identify and isolate. In addition, we had to consider that in our ambulatory care settings, we have a policy for high consequence infectious disease that we're identifying and then transferring. So primary, specialty care, those sort of care environments, we're not doing things that are aerosol generating for coronavirus patients, and certainly not collecting testing there. We are identifying patients and moving them out because most of our ambulatory care settings do not have respirators and have not been fit tested. That's different in some states where that's the state requirement, but the majority of our ambulatory care settings do not. We also know that there are many health jurisdictions that touch our various care settings, and that they have different capacities. And so as we were planning our approach, which you'll see here in a moment, we had to take into consideration that some health jurisdictions are able to respond quickly, and others have been very bogged down with the amount of requests and PUIs identified in their area. Finally, PPE is limited, and I know that we've had really more concerns over surgical masks at this point than N95s even. But we do have guidance from CDC regarding N95s and the documents that were shared earlier about prioritizing use of those. On the next slide, you can see this is just a really simple diagram that kind of gives an overall explanation of our patient flow. We ask screening questions at the point of entry. We actually ask about travel to China, and we have initially since we turned the screen on, to cast a wider net, and we ask about travel within the last 30 days. Because of a case in which the patient did not present for medical care because they were not symptomatic until day 15 or 16 after their travel. And because we know with this pathogen that we're seeing this longer prodromal period where patients may not be sick enough to present for care. So we've expanded our window of what we're requesting. For hospital-based settings, for all settings, we provide the patient a mask initially. Most of our settings do have sort of masks right at the door with signage as well. And then we move the patient to another room in order to screen them for symptoms. On the next slide, you can see the breakdown. And what I'd really like to indicate here is the difference between response in our hospital-based settings and our clinic-based settings. So if a patient screens positive for symptoms, in our hospital-based settings, we respond by placing the patient in negative pressure and donning the contact airborne, et cetera. In our clinic-based settings, again, we do not have fit testing throughout all 1,000 of those clinics. And so we are using contact and droplet PPE, placing the patient in a private room and notifying the local health authority. We're not conducting conducting testing, collecting lab specimens, really providing care, simply holding the patient until we get guidance from the Department of Health on the right location to send the patient. Next slide. And then finally, across the enterprise, we are doing a number of other conservation steps, and I'm sure these are things that are in place across many of your facilities. I kind of added the control categories here based on the documents that were shared over the weekend, but certainly we're housing patients in rooms and separating them. The administrative controls, I think, are, it's important for us to talk about these techniques like limiting entrance into rooms and bundling care, excluding visitors, not for coronavirus confirmed cases or even PUIs specifically at this point, but all of our other patients in isolation. Because I feel sure our facilities have more patients in isolation for influenza right now than for coronavirus. And we're using large quantities of PPE for these patients as well. So if we want to be smart about conservation, we need to focus on conservation of PPE across all isolation types as we await updates in our supply chain. And then in the event of surge, cohorting patients, personnel, and just-in-time fit testing begin to make more sense. Obviously, if we don't have confirmed coronavirus patients in our facilities, cohorting isn't really applicable. Next slide. And then finally, we actually do have respirators in our system that were identified last week as being expired, and we've held them. And I was glad to see the CDC guidance recommends, the opportunity to use those things that are out of date when the situation warrants it. So we will be holding those in the event that we get very critical with our supply. Extended use of using the same respirator for repeated use and not removing it is something that, again, we will not be considering at this point, but if we get a surge of coronavirus patients and we're cohorting it, then makes sense. Reuse, again, does not make sense for this pathogen because of the contact nature, but may be appropriate for us to consider for the N95s for our TB patients because of the different route of transmission there. So that is just sort of an overview, and I know I moved through that pretty quickly, but that's the way that we're handling the crisis in our health system.
Great. Thank you so much for that. I think hearing the realities and the pragmatic approach you've taken is extremely helpful for everybody, and just in general, great job. We now have a few minutes left for question and answer. You're able to submit questions online, and if you will submit them, we will read them and respond to the best of our abilities.
So one of the first ones is actually for Marie. I think they just wanted a clarification of the other masks that you mentioned, other than an N95, that could be used.
Yeah, so if you go onto our strategies webpage, there is a link that will take you to the NIOSH page for other disposable filtering face piece respirators that would be okay to use. So these include the N, R, and P series, and then the higher numbers, so like 99 and 100, just means that more particles are filtered out by using these respirators.
Great. We have a question in about eye protection. The question specifically is, does it have to be goggles or a disposable face shield, or can you also use safety glasses? Unfortunately, safety glasses don't provide the wraparound protection that we would prefer. You can imagine that if they were to slide down your nose, your eyes would be somewhat exposed, so that's not an option. But it's an important thing to have asked, because I can imagine that many clinicians and staff members in the emergency department in particular, who are accustomed to wearing safety glasses, might think that that's sufficient. In this case, it's not. There's another question about home care. One asking whether if you're going to send people home with a home care kit, should you include a respirator for the people at home, or would a disposable surgical mask be a better choice? And I think the practical answer here is that because we're dealing with a lower risk situation, we're not asking family members to acquire specimens, to stick a swab in someone's nostril, generate a sneeze, that kind of thing. And we have the ability to ask that the patient at home use source control when there's somebody else in the room with them, that we don't need to rely on significant respiratory protection at that point. A surgical mask would be fine, and in fact, being able to send several of them so that people can use them and throw them away appropriately would make more sense, because reusing a respirator, as you just heard, in this setting where contact transmission is likely to be an issue, would be a bad idea. We wouldn't want somebody reusing a respirator that had respiratory secretions accidentally smeared onto it. So bottom line, not necessarily a great idea to send respirators home with patients, but a stack of surgical masks might be a better option. Related to that is a question that we received about reusing respirators. These are the disposable filtering face pieces, the N95s that we're all used to. Yes, you can do it for tuberculosis, because tuberculosis is all about filtering and not about contact transmission, but that cannot be replicated for people providing care for coronavirus or other respiratory viruses that are transmitted through contact. What else do we have?
So we're getting a question to go through the kind of contingency that was placed in the guidance about using respirators past their shelf life. Marie, can you speak to those contingency plans and the implications of that from the guidance?
So we're calling these two strategies contingency capacity strategies. So these are strategies that, might change, might have an impact on patient care and the worker safety and health in the setting of a shortage. So we touch on two potential strategies that can be used for contingency capacity. That's use of respirators after their intended shelf life. It's important to know that, using respirators past their intended shelf life may put the worker at risk because the respirator may not perform to the requirements for which it was certified. So we're working on a little more, fleshing out a little more the guidance surrounding that, and that should be forthcoming. We also do introduce the concept of extended and limited reuse. Note that we're not telling healthcare facilities to go into these strategies at this point in this response. NIOSH does have some recommended guidance on how to implement that if the time comes for that. But as Dr. Bell said, we do think that there is a contribution of contact transmission and thus fomites for this virus. So, if we had to go into extended use and reuse, extended use would be more preferable because extended use minimizes the healthcare worker touching the respirator between patient encounters. So again, we're not ready to recommend that healthcare facilities use these strategies just yet, but we're working on providing more guidance if we get there. Anita, Dr. Patel, do you want to add anything to that?
No, I think you hit on everything. Thank you.
We have one more question, a clarification request about healthcare personnel using respirators for home care, and that's a very different thing. So what we were talking about earlier is sending a stash of equipment home with a patient to manage themselves or their family members. With a healthcare worker, if we're sending somebody in to provide healthcare and manage a sick person, there are two things that are quite different. One, they might be doing things that are likely to generate exposures, like obtaining specimens, that kind of thing. And then the other thing is this person's job is to go from one patient to another. And so their ability to contribute to cross-transmission is materially different from a household member providing care for a loved one. at least we assume a household member is not going to provide care for many loved ones across the community all at once. So with that in mind, we would continue to recommend that healthcare personnel going into homes use an N95 as currently recommended. I will also, though, loop back and say that that's our current stance, and if things change, we may be able to step back from that a little bit. And as soon as we have that ability, we will be messaging that broadly.
Great. We also have a question around specific guidance to law enforcement officers. This was put through the chat mechanisms, but I wanted to repeat it since I know there's a lot of interest. So while specific guidance related to law enforcement officers doesn't exist, there's actually a combination of guidances that law enforcement officers and personnel can use. Law enforcement officers that are performing emergency medical care services should follow the guidance that we released over the weekend for EMS personnel. Otherwise, in their day-to-day on-the-beat activities, law enforcement officers should follow the guidance for businesses and employers that was released just a few days ago. However, if officers are in contact with people with known coronavirus, then using the risk assessment guidance that was released a few weeks ago would make sense. So while there isn't specific law enforcement guidance, because depending on what they're doing in their course of business, has them fall into different categories, being aware of all the different guidances will be helpful. If there's further questions, we'd be happy to reach out to these partners and walk them through that, but wanted to make sure we could clarify. Looking right now to see any last questions that we might be able to answer on here.
There's one last question asking about the regulatory aspects of protective equipment use. And while the question is asking about, will OSHA change their standards, I think it's much more in the healthcare sector about CMS and deemed status organizations changing what their surveyors look for. We are in active communication with CMS and all of the deemed status survey organizations, and we will be working with them going forward. If recommendations change or if supply changes mean that we have to change how we practice medicine, they will certainly be part of that conversation so that healthcare systems shouldn't be penalized incorrectly for something that they really can't avoid. We don't intend for that to be the outcome. With OSHA, it's a very different thing. I certainly won't speak for our colleagues there, but they have requirements that are unlikely to change quickly in response to something like this. But at the same time, I would not expect those to get directly in the way of implementing interim temporary activities.
Great, and there was one piece of clarification. I believe it was Dr. Bartle's presentation that talked about how their prompt used a 30-day window instead of the 14-day window. That was a system and facility level distinction from CDC's guidance, and we think that's great. If facilities and hospital systems prefer to cast a wider net and that works for them, then that's a decision that they're welcome to make. CDC's guidance currently has a 14-day window, but again, going above and beyond that is certainly not something that CDC is going to frown on. And then for a few housekeeping, we've been asked if they have access to slides. This presentation is being recorded, and we will work to get a link to the recording out to those who are interested. And for those of you today who had questions that unfortunately we ran out of time and weren't able to answer on the call, at the end of the presentation you'll see a task force mailbox. Please feel free to use that mailbox, and we will do our best to answer your questions as quickly as possible.
Great. Well, with that, thank you very much to all of our panel participants today. This has been very helpful, and a huge thanks to everyone who took the time to dial in. Your willingness to join us on calls like this is key to our ability to share information effectively and hear about real questions from people in the front lines. We will be making an effort to have a series of similar engagements as more information is developed, as we learn new things. The engagements might have a range of focuses, and as that turns out to be the case, we will reach out to the appropriate groups. But please be looking out for opportunities to join us again. And once more, thank you for your time today.